Thanks for joining us at the Canadian Breakpoint, a Canadian infectious diseases podcast by Canadian infectious diseases physicians. I'm Summer Stewart, back with Dr. Rupeena Purewal, pediatric infectious diseases physician from Saskatoon. For this episode, we invite Dr. Camille Hamula to introduce us to the BCID2 panel. Dr. Purewal.
All right. Thank you for joining us on another episode of our podcast, the Canadian Breakpoint. So today we have Dr. Camille Hamula, who's a clinical microbiologist with 10 years of experience in hospital setting in both Canada and the US. She's a public health program lead in Saskatoon here for sexually transmitted infections, antimicrobial resistance, and enteric bacterial infections. She's also the clinical lead for laboratory quality and safety in Saskatchewan Health Authority. And Dr. Hamula has published extensively on novel diagnostics for sepsis, antimicrobial resistance, and other bacterial pathogens, and has used her findings to implement provincial changes to molecular syndromic panel testing, antimicrobial susceptibility testing, and syphilis testing, as well as improving turnaround times for testing for Neisseria gonorrhea and chlamydia trachomatis. Dr. Hamula has also recently implemented province-wide improvements to microbiology quality control and quality indicators in both urban and rural laboratories. She's involved in several committees for CLSI, which is the Clinical Laboratory Standards Institute, and has recently written guidelines and documents for diagnosis of congenital and neural syphilis, as well as the detection of anaerobes in clinical specimens and blood cultures. Dr. Hamula is dedicated to ensuring laboratory quality and quality patient care. Thank you so much for joining us on the podcast today.
Thank you for that great introduction.
So today we're going to be talking about a newer panel to us, which is called the BCID2 Panel. And so for our listeners who can range from clinicians to microbiologists to nurses to residents to anybody in healthcare or not in healthcare, I wanted to start off by actually introducing the panel and if you can elaborate kind of what the panel consists of, how the test works, and specimen processing and turnaround times.
Sure. So the panel is actually what's called a syndromic testing panel. So it's a multiplex PCR, meaning that it detects multiple targets out of one specimen. In the case of this panel, it's from BIOFIRE Diagnostics. So it's the blood culture ID panel. It's the second version of it. It's been around for a while in the US. There was a first version that was released in, I think, 2014 or 2015. It was quite a while ago. But it has only recently started to be used in Canada.
Okay.
And it's a target-based amplification nested PCR. So what that means is there's multiple sets of primers. There's one big amplification at the beginning, and then there's multiple sets of primers for each specific target that then detects each specifically in a second amplification.
Okay.
So it's a test that's performed on blood culture. It's performed on positive blood culture broth. So positive blood culture broth from either a BACTEC bottle or a BACT alert bottle.
Yeah.
And the broth is taken and inoculated into the test cartridge, and then you put some buffer into the other end. And it basically is a 1 hour test. So once you do that, put it into the machine where there's thermocycling that happens. And 1 hour later, you get a printout. It's very easy to run. You can I've trained in the past high school students, summer students to set this up, and they've been able to do it. So It's actually very straightforward. It's Health Canada approved and minimal hands-on time. So that the setup itself takes about 10 minutes.
Okay.
And then you run it, and then about an hour later, you get your result. And there's 43 targets in the panel. So what that gives you are gram positives, gram negatives, yeast, and then there's 10 or so resistance genes that it will call out as well. So for MRSA, vancomycin-resistant enterococcus, all the main antimicrobial resistant organisms.
Okay. And so you talked about that it's validated for positive blood cultures.
Yeah.
And then are there other clinical samples that's been validated for, or have you guys tested anything in the lab?
So the instructions for use from the Health Canada approval are for positive blood culture broth. Okay. You can validate it on, I've seen it used before on sterile fluids. So for example, sterile joint fluids, or sterile like peritoneal fluids. So we have used it. That's an off-label use. So if you want to validate it, you can, or you can use it off-label and put a disclaimer on it. But we We haven't really had enough cases yet from the sterile joint fluids to consider it validated. So what we're doing is running it off label and then putting the disclaimer on until we get enough numbers that we can consider it's validated. But you can use other sources. The company that makes the BCID2 panel also has a joint panel. They have a joint panel for sterile fluids, but it has slightly different targets on it. Okay. And it doesn't have QD bacterium acnes, which actually is on the blood culture ID panel. So we prefer to use the blood culture ID panel for that reason, because a lot of the ortho samples that are being processed in the lab, they want that organism called out. Right. So we chose to do it that way instead of going with their joint panel. But I know a lot of sites are looking at the joint panel as well. And there's literature on that. Yeah.
Okay. And then just to touch on so once the specimen is processed, and you mentioned that it takes about an hour to run. And then, so basically that's like from the time that you place this onto the machine and then you have the report within that hour?
Well, so yes, so you collect so you should probably start with the patient's blood culture getting collected. So you collect a blood culture from the patient. That typically needs to incubate in an instrument in the lab for minimum 6 hours before it goes positive. Sometimes they go positive at 3 hours. I've seen them as soon as 3 hours. 6 to 8 is more typical, sometimes up to 12, sometimes up to 48 even. That's all, like, it depends on the organism. But once that blood culture flags positive, then you take the positive broth and load it onto the BCID2 panel. So then from the time you have that positive blood culture, you ground stain it, you set up that blood culture panel at the same time, and then the blood culture panel is done an hour later.
Okay. Yeah. And then once the report is printed, so on there you'll have the identification of the organism. Yeah. And if there's any resistant genes that are present, then that would also be picked up. Is that kind of what's delivered on the report?
Yep, exactly. Okay. So you'll get a gram stain result, and you should always use the gram stain to interpret with the BCID2, just because sometimes there are things that aren't on the panel, the PCR panel, that will be in the bottle. So then you want to make sure that you have both. And so you do the gram, you'll get that right away. And then the report will come out an hour later, and it'll have all of the organism names like Staph aureus, Escherichia coli, Klebsiella pneumoniae. And then it'll have if there's an antimicrobial resistance gene detected that's on the panel, then it'll list it as well. Yeah, it's all at once.
Perfect. And so obviously in clinical decision making, like for me as a clinician, I think that's very valuable information, especially if there is a resistant gene present and I wasn't expecting it, then obviously I can add on antibiotics, right, to cover or change antibiotics. So have you kind of in your experience noticed, has this been influenced the kind of antimicrobial stewardship efforts? Are people narrowing their selections and changing their empiric antibiotic coverage based on this?
Yeah, so I've noticed often it influences kind of narrowing of therapy. So they'll be on something pretty broad to begin with. And then when they get that result back, they'll feel more comfortable de-escalating. Right. The ones that I've noticed it being used on the most are MRSA versus MSSA is one. Also, when typically in Saskatoon, we don't have a super high CPO rate, but if we do pick up a CPO, then that will affect how they're being treated. Right. And the other sort of determinant for gram negatives is if you have an Enterobacterialis versus a non-fermenting organism like a Pseudomonas or a Steno, you will have different treatments potentially. So then differentiating between those two groups. Also for the yeast, it's very useful for yeast because there are some intrinsic sort of resistances with Candida. So Candida krusei, for example, is resistant to fluconazole. So if you call that one out, you won't be using fluconazole. Whereas if you have a glabrata, you know that they're likely to be resistant, but not necessarily. So then you may choose a different drug, or you may wait to de-escalate, as opposed to something like Candida albicans, which in Saskatoon is very susceptible to most antifungals. Right. So those areas I've seen benefit for sure with this panel.
Yeah, no, that's fantastic. I mean, like I kind of practiced when we weren't using a lot of the panels or anything like that. And so then you're waiting on, even probably before MALDI-TOF, when you were waiting on, organism identification, speciation, and then you have to wait another 24 to 48 hours for the susceptibility patterns to come up. So I think this is fantastic that we have newer panels to help with clinical decision making. So it's fantastic. I know that you recently conducted a pilot study here in Saskatchewan.
Yeah.
So can you walk us through kind of your study design and what was things that you learned from that
So
study?
that was a little bit of a different use case of the BIOFIRE panel for blood cultures. In that case, we chose to use it first in sites where they did not really have the staffing level necessary to maintain blood culture workflows. So they had their hospitals that were in rural settings or smaller towns where they have blood culture cabinets and they need to have them, and they maybe do a gram stain, maybe they don't have the staff present to do the gram stain, so they may not be able to maintain the level of technical staffing needed to actually like perform and interpret the gram. So we chose to use the BIOFIRE panel in place of the gram stain. So these sites were already not performing gram. They were sending their positive blood straight to the reference lab, whether that be RUH or the Regina, the RPL lab in Regina. So the two, depending if you were north or rural south. So the two sites we chose to roll it out in first were Melfort and Swift Current. So Melfort, they were just sending all the bottles to Saskatoon. When they're positive, they weren't doing any gram staining because they couldn't maintain proficiency in gram staining. So they did not have the staffing. So they had converted their lab from an MLT lab to a CLXT lab. So those are designations of types of lab staff with different levels of training and expertise. Right. So in order to read and interpret a gram stain, you need a med lab technologist in this province. You can't use a CLXT. A CLXT is a more general technology. I don't even know the difference, to be honest, in the training, but I know that there is like a different amount of training in different time periods too. So they converted their lab to just have blood culture cabinets. So we weren't really taking anything away from the process. We were just adding this in to kind of help. And it did improve the turnaround significantly in the physicians actually getting an actionable result. And we did not find a lot of discrepant results from that. So there were not a lot of discordances with the culture. The only things that were discordant were cultures where, you know, it grew something that wasn't on the panel.
Right.
We had one that was it was a group B strep positive in Melfort, and it did not grow in culture, probably because they had received antibiotics initially that killed it. So they still chose to treat that patient. So there weren't a lot of really concerning discrepancies. And we've since rolled it out in the lab in Lloydminster as well. So they were also not performing. They're performing grams, but they weren't performing the culture. And they were sending their culture to the Battleford Union Hospital. So it was like a 48-hour delay.
Right.
So we inserted the BIOFIRE blood culture panels there to sort of as a stopgap, so they don't have to wait 48 hours to get a culture result. And so far it's been working pretty well.
Got it. And so in that initial, like where that group B strep positive, like did you have a gram stain at least that was positive? And then
that case, no, there was not a gram stain because it was from Melfort where they did not perform the gram first.
Oh, right.
So the gram stain was after.
Okay.
Yeah. So it was gram stain positive for some gram positive cocci, but it never grew out. So we couldn't confirm it with a positive culture growth.
And so in terms of, for instance, if I have a specimen and we don't, let's say we know that the patient received antibiotics prior, and then we send a blood culture just to see if it's still persistently positive or not, but it comes back negative. But I feel like my pretest probability that there was a bacterial source or bacteremia of some sort, would you run this panel on there?
If it's like positive in the blood culture instrument. So if the growth got over a certain threshold, so there's a minimum threshold that it has to reach in order for the machine to flag it. If it flags it over a certain threshold of CO2 production, then we'll pull it out and then we would process it. We won't process it if it doesn't flag positive.
That's fair. Okay, perfect. And so then from that pilot study, what information did we gain?
We gained that introducing the blood culture panel improved the turnaround times by, I think the average from Melfort was 48 hours. So that's a significant difference. And also, you know, it covered most pathogens. There weren't a lot of surprises. So the panel itself, like in the literature, it says it covers 95% of blood culture isolates, and that's pretty accurate with what we see. And so we also found just some of the use cases were what we would expect, right? So people would, you know it was an MSSA, and then they would de-escalate the treatment sooner. So there were some examples of that from that pilot study. But it was just sort of a feasibility study to make sure that they were agreeing, and they matched the gram in most of the cases. So it is actually something you can use. off-label usage, but you can use it as a replacement for the gram stain in sites where you're unable to perform one. It still improves patient care over not having anything.
Right. Oh, that's fantastic. And then, so if hospitals or centers are kind of interested in bringing this to their lab, what does the implementation look like? Are there like some requirements, equipment, assays, costs, that type of thing? Like how do we?
Yeah, the implementation, so the reagents themselves are fairly expensive. So we struggled a bit with convincing, I guess, administration that they should be paying for this, because the reagents are for the BCID panel. I think it's depends on your site and your volume, but they can be up to $160 a test, Canadian, or 130 to 160, somewhere in that range, depending on your contract for each result. So that's fairly expensive. I mean, you're getting 43 targets out of that. So when you think of it that way, if you split it by 43, it's actually cheaper than a lot of other methods. But like the people who were counting the money don't think that way.
Yeah, exactly.
They see the upfront cost and sort of, oh my gosh, that's expensive. The equipment itself is quite simple. It's just a small, it's called a BIOFIRE torch. And the smallest unit you can get has 2 modules in it. And I don't know if you've ever seen what a Cepheid Gene Expert looks like. It's kind of a little benchtop unit with multiple modules. This is kind of similar, just slightly different design. It's a little benchtop unit that has multiple modules, and you can add onto it, so you can build them up if you add more. So you start with 2, and then you can get 4, 8, and so you can scale up that way, and they go vertical, so it's safe space. And they aren't, usually when you start ordering the cartridges, they give you the instrument as a contract called like a capital lease or reagent rental. So it's not like you're paying upfront for the machine itself, but if you were going to, I think they cost about $90,000 last I checked. Don't quote me on that. That was a while ago, but they're not incredibly expensive for lab equipment. It's the reagent packs that are expensive, because it's all included all in one. You have extraction and 2 sets of amplification and detection. So you have like this, it's called a film array. It's like a flat plastic kind of pouch. And so that's expensive. But we justified it in the sites that were rural sites by eliminating transport costs by implementing this. So what we were doing initially was paying for stat cabs to send blood cultures that were positive to the referral sites. So we were paying quite a bit per cab ride. I can't remember the exact amount, but it was probably $500 or $600 per cab ride to transport things. Like basically when it goes positive, you call and then you get the cab to come and transport it. So the amount that we saved doing that outweighed and just switching to normal couriers, that outweighed the cost of the cartridges. So that's kind of how we justified getting it in.
Got it.
And then in Saskatoon at RUH, we've started using it on the ICU. And so we've been targeting, the other way you can get it approved is just to target certain groups of patients who need it most, so that your overall reagent pricing is not so sky high. Because when we did the calculation, well, what if we rolled it out on every positive blood culture in the province? It was too expensive. So we justified by targeting the critical care patients, and we're doing that pilot right now at RUH to see how that's working. So that was how we sort of got it in at the hospital, because we don't have stat cabs we can eliminate here. We just kept it under a certain minimum amount. And we do fairly tight diagnostic stewardship of the tests. So microbiologists have to, if it's not a critical care patient, we have to approve it. We have to review the results and make sure they're being used appropriately, not over-ordered. We don't run it on multiple sets from the same patient all collected in the same time like we do for set per patient. Then we have like a replica limit. So we do some steps to make sure it's not being overused.
Yeah. And you actually mentioned a really good point, which is on diagnostic stewardship as well, because you know, knowing that these molecular tests can be very sensitive, it's important to make sure that you have a good pretest probability before sending it. And that the samples are, reasonable and validated.
So it definitely should always be on a positive blood culture. And that's exactly true. Like it's detecting dead organism. It doesn't necessarily detect live. I mean, when you have a positive blood culture, there's so many cells in there. By the time it amplifies to the point where it gets brought off the machine, that it should pick up whatever's growing, but it could pick up something that's not viable or doesn't grow very well.
Perfect. So it sounds like these rapid diagnostic panels are really becoming a good framework for kind of clinical decision making and helping us clinicians, especially in our day-to-day job, which is nice. So what do you see the future of this? And are there newer generations of the panel or emerging technologies that are being evaluated at this time?
Yes, so there's a lot of versions of syndromic panels. It's not just BioFire. BioFire was probably one of the first major commercially available ones, but there are other companies that make them. There's too many to list. But in our lab, we have a few other ones too. So there are some from GeneXpert. There's some from CGene. They have a pneumonia panel. We have a meningitis panel as well. So there's different, like based on the clinical presentation, you have a different syndromic panel. Right. So these are becoming much more commercially available, easier to set up, less technical expertise required. So maybe 20 years ago, you need a specialized molecular lab in order to set these up, and you need people to manually set up all the reactions, and it would be very labor intensive. And now it's something that anyone who's got minimal sort of pipetting skills can do and set up. So you don't need to be a skilled technologist to do it.
Right.
And the BioFire company, BioMary, they have now what's called Spotfire. It's like a kind of point of care BioFire. It's not really, it's meant for clinics, but it has some of the common targets you'd see in like a family medicine clinic. So things like, a throat sample can be loaded on and run for strep, but they also have other things like the cause of the common cold, different common pathogens you'd see in a family medicine setting that can be set up in the clinic. So they have those coming out now, like much more point of care syndromic things are starting to come out. But I see it becoming even more user-friendly and easy to use in the future. And it's really important too. So at Commit conference this year, there are a number of presentations about pairing your PCR tests and panels with culture. So you're making sure that you interpret them with the culture alongside it. So that's also really important. We see that with our meningitis panel, like we run them and they go positive, we report them right away, but then we also have to have a bacterial culture that goes with it. Right. Similarly, for pneumonia panel, you should really have a bacterial culture that goes with it, especially because some of those pneumonia panels, the one we're running doesn't have too many targets on it, but the BioFire one has a lot of targets. Right. And so knowing the quantity of the bacteria present is actually kind of important for some of the ones that could be normal flora or could be a pathogen, like Haemophilus influenza, or, you want to know how much is there. So it's always important to have a culture with it.
No, that's a really good point for especially our clinicians out there. Yeah. All right. So it sounds like there's a lot of different panels to learn about. So thank you so much for talking about the BCID2 panel today with us. For my audience, which like we talked about, could range from multiple different types of specialists or clinicians and laboratory diagnostic folks. So for our audience kind of listening, how do you feel like incorporating rapid diagnostics like the BCID2 panel into their practice? Like, what are some of the take-home points that you would want to emphasize today?
Some of the take-home points, I guess, one would be that they're not necessarily a final, like you can use them to inform your patient management. They're accurate, but they're not the final answer. So you always need to have another method with them. There are some limitations too. So for example, when you're detecting resistance for Staph aureus, sometimes you could detect a promoter and the resistance gene itself is missing in that particular isolate. So you'll detect it as being positive, but it's actually phenotypically, when you do the susceptibility, doesn't match, and it's MSSA. So there are things like that. You have to correlate it with your culture susceptibilities. So just make sure that you always check those culture susceptibilities to see after you get the initial result. But you can kind of treat it like a screen almost.
Yeah.
and then it is pretty accurate when you do it that way. The other thing is to consider what source you're detecting something from. Blood culture is a pretty easy one in some ways because you amplify it first, so you get a lot of what's present. But if you're doing direct from stool, for example, PCR, a lot of the time that's a very complex matrix. It has a lot of background, so you may or may not pick things up in there that could be present, or you may get interferences. So just always consider the source you're getting it from.
Right.
Yeah. So those are kind of my main two takeaways.
Awesome.
Help your microbiologists if you have questions.
Yeah, exactly.
Always the takeaway, right? Always call us if you have questions, because we can explain, if you're not sure about something, or why is this not getting run, or why is this being canceled, or
No, that's a really good point. And I think like using your resources at your hospital, like your local microbiologists, on-call or IT docs, I think is really important to have these discussions.
There are some hospitals, not ours, but there's some hospitals in Canada, I know, that the microbiologist decides what method gets set up. So based on the patient, like they actually review it and they decide, okay, this patient needs a BioFire, or they need another PCR to detect like MRSA, or they need so they kind of triage based on a lot of different factors. So So it's not the necessarily like I guess the point of what I'm trying to say is don't get fixated on one method.
Yeah. No,
Yeah.
that's totally fair. Yeah. And I think it like really just like how we talked about like with rapid diagnostics and these molecular methods, although they're fast, they're quick, they give us the information sooner. Again, we have to have kind of the right clinical setting as well.
Yeah.
And ensuring that plus like validating it with additional samples. So I think that's really important information for our clinicians out there. So thank you so much, Dr. Hamula. That was a really nice introduction and in-depth conversation about BCID2 panel. And I'm sure as we continue to use and introduce other molecular methods in our lab, we'll be chatting. And so thanks so much. Really appreciate it.
Thanks, Rupeena.
Thank you so much, Dr. Hamula. Would you like to be a guest on the podcast? Email us at thecanadianbreakpoint@gmail.com. And don't forget to follow us on X at CA Breakpoint. See you again soon at the Canadian Breakpoint.